Hi, my name's Tom Jung, and I'd like to thank you for giving me this opportunity today to speak to you about the FGI Guidelines. I know you'll be working on the 2010 edition primarily during this upcoming semester. However, as I think you'll see from my presentation, the FGI updates the guidelines on a regular basis, and I assure you that the underlying principles and baseline thinking that informs earlier editions of the guidelines continues through 2010 and into the 2014 edition, which was recently published earlier this year. Personally, I'd like to give you a little idea of my background. I served as director of the Division of Health Facility Planning in New York State Department of Health, and I spent more than 25 years overseeing the healthcare facility planning, design, and construction program for New York State. I have also served on guidelines revision committees for the past 14 years, and I've been an FGI board member since 2003. I believe that my previous role as a regulator and my experience in working on earlier editions of the guidelines gives me a unique insight as I fulfill my current role as CEO of FGI. In order to understand where the guidelines have been, where they are today, and where they're going, I think it's important to give you a little insight into the history of the guidelines. The document actually was born as a federal government publication. It was inspired by lessons learned in caring for World War II combat casualties. And in 1945, the federal government passed the Hill-Burton Act, which mandated local and facility planning for healthcare facilities and provided some funding with the expectation that the healthcare infrastructure of the country would be improved by it. In 1947, the first guidelines were published to support this, and in 1973, the term minimum requirements first appeared in the title. Now, it's important to note here that for earlier editions of the guidelines, less than 20 federal employees completed the development process, the review and the revision process of earlier editions of the guidelines. And I want you to keep that in mind because that's certainly not the case today. In 1984, the federal government made a concerted effort to reduce regulation. And as part of this deregulation effort, President Reagan terminated the guidelines as a mandatory U.S. standard. However, there was great interest on the part of the design community and the healthcare industry to keep the guidelines going because they were viewed as an essential background and guideline document to assist in healthcare facility development. So the Public Health Service invited the American Institute of Architects and the Academy on Architecture for Health, which at that time was the Committee of Architecture for Health, to take over the production of the document with assistance from the Department of Health and Human Services. So in 1985, the AIA assumed the effort of developing and publishing the document. And one of the first goals of the core group of individuals who took over the effort, one of their core goals was to develop a more broader base for future documents. So they created a Health Guidelines Revision Committee, or HGRC. And as you can see, in 1987, that committee consisted of 52 members. It increased to 62 members in 1992, and it included 3 state authorities having jurisdiction, or AHJs, because it was viewed as critical to have government participation, particularly at the local level. In 1996, the HGRC grew to 82 members with 9 state AHJs, and the 2010 edition that you'll be working with this year had more than 115 members on the HGRC, and it included more than 15 state AHJs. Because the efforts of developing the document and publishing the document were viewed as separate and distinct, the Facility Guidelines Institute was created in 1998, and it was done to protect the intellectual property of the guidelines. That group, the FGI, continued to partner with the American Institute of Architects to publish the guidelines until the 2010 edition, where FGI partnered with ASHI, who published both the 2010 edition and the latest 2014 edition. FGI's mission statement is there on the screen for you, and in order to truly understand the passion behind what FGI does, I want to point out two elements of the mission statement that I think are important. The first is the term consensus-based. As I showed you earlier, 20 or less people developed earlier guidelines when it was under the auspices of the federal government. Today, it is no longer the opinion of just that few and small number of professionals. And then the second concept contained in this mission statement is advised by research. The intent of FGI is not only to make healthcare facilities as safe as possible by being supportive, but also to advance healthcare environments where possible. And a good example of that was in 2006 when the FGI guidelines mandated single-bedded rooms for new hospitals. And as you can imagine, or as you know, that was subject to great debate. However, the FGI was comfortable in making that a new minimum for a number of reasons. One, it was the consensus agreement by both the HGRC members as well as public participation in the process. And the FGI had science and research to support that initiative. So that's just one example of where the guidelines tried to be as proactive as possible. Now, there are some elements of the makeup of the group doing behind the guidelines that may not be widely known. The FGI board itself is, as you know earlier, was as I indicated earlier, was formed to protect the intellectual property of the guidelines. And that board provides strategic direction for the guidelines, and it manages the HGRC. All members of the HGRC and their subcommittees are appointed volunteers. There is no one either on the HGRC or on the FGI board receives monetary compensation. The only difference now, and this was changed about 2 years ago, is that a part-time CEO position was deemed necessary, and that's the position I serve in now, and that's the only position that receives compensation. You also should note that 100% of the income that is derived from a sale of the publication and the document goes right back into the process. It either is used to support development of future guidelines, or it goes into research efforts that are intended to inform future editions of the guidelines. I talked earlier about the multidisciplinary nature of the HGRC in an effort to increase the consensus basis of the document. And here's a breakout of the 2014 HGRC just to illustrate how truly multidisciplinary it is. And as you can see, we had participation from all of the design professions, as well as medical professionals, both doctors and nurses. We had participation from healthcare facility administrators and owners. We had AHJs from both the state and federal level, and we had contractors involved. The one element of participation that I'd like to point out to you as becoming very important is the infection control experts at 7%. As you can imagine, by events today, concern over infection control continues to increase, not only to improve the safety and outcomes of our patients and residents who receive care in our facilities, but also because of concern over the increasing cost of healthcare and the need to try and reduce the need for medications and return visits. So our infection control experts are really critical participants because they review all of our proposals, both new and existing, and they try and make a decision in terms of how it comports with good infection control or infection management practice. Now, I talked about how the consensus based process for the guidelines is something that was initiated early on. And it's important to note that I think, as you saw from the earlier slide, there is really a collective multidisciplinary experience that participates in each HGRC committee. Um, there is also professional stakeholder consensus. We have a number of both professional and facility-based organizations and associations that participate either as within the HGRC or as part of the public process. We have a number of both federal and state AHJs that participate. It's important to note we do not receive any compensation or support from any manufacturers. There is a strong public review process where the public is allowed to submit proposals for future editions of the guidelines, and the public is also invited to comment on revisions that we propose. We continue to support clinical and evidence-based research to inform the guidelines, and all of this is really the background as to why the guidelines is, each edition of the guidelines is an evolution from the previous editions. Now, this is probably couple of the most important slides that I want you to focus on, and that is why the guidelines are important. They're important because they are intended to set minimum standards for our healthcare facilities, both for new or renovated healthcare facilities. But the concept of minimum is not easy to define. A minimum is, we call it a minimum standard in our current documents, but they also could be considered as baseline requirements that are vetted through our open process. They can also be considered as a consensus of the HGRC and of the public that participates in our process. And they can also be considered as standards that are advised by research, science, and expert opinion. But the concept of minimum is in fact is debated continuously internally, both at FGI and within the HGRC. As you can imagine, there is no easy definition of minimum. In fact, a minimum standard that's contained in the guidelines, it can vary by philosophy of a healthcare provider. The concept of minimum can vary by the scope and scale of a facility project. It can vary by state or by state regulation. It can even be impacted by politics, or it can be impacted by geography, that is a region of the country, or a local culture. So there is a constant tension within the committee and FGI regarding what is an acceptable minimum. One thing we are certain of is that the healthcare environment is not static, but it is continually evolving. And so therefore, the idea of what a minimum is also must continue to evolve. And that's why we have this consensus process, why we have multidisciplinary participants, and why we seek evidence and research to support our requirements. In fact, in the future, we are considering revising the term minimum. It has been said that the concept of minimum, particularly when you're dealing with a state authority having jurisdiction, can be have a negative connotation. Facilities may feel that a minimum is not enough, and then facilities may feel that minimums go too far. So one of the ways that FGI feels that it could address this issue is by calling them, possibly using the term fundamentals. We believe that the term fundamental may actually be a better reflection of the philosophy of FGI and the guidelines. Now, one of the things you may ask yourself is, well, how do the guidelines impact facilities management? And I think that when we look at that, answering two general questions can be informative. The first question is why? And the answer is quite simply, the guidelines are the recognized standard for healthcare facility design and construction, not only in this country, but abroad. Second question is, how do they impact facilities management? And they impact them in two very general areas. One is in the area of facility operations, and one is in the area of regulatory compliance. So let's look at these a little closer. When we look at how the guidelines affect operations, if you look at part 1 of the document, you'll see two major areas that are addressed that are important to consider when using the guidelines. As you can imagine, as you certainly know, the guidelines are a physical plant standard. But as we all know, form does follow function. And while the guidelines tries to stay away from directing operations, it is the FGI's opinion that the guidelines must absolutely be informed by operations in order to be effective. So the functional program is something that was actually first initiated by government, both federal and state, as a means of assessing projects during their approval process to ensure that the eventual project that is approved was consistent with what the goals of both government and the facility were. So the functional program is something that has evolved greatly over subsequent editions of the guidelines, and it's very well defined in both 2010 and 2014. It is owner initiated, and it helps to develop direction for the design team. It is a good recorder, historic record of decisions that are made, and it helps organizations to set priorities, both financial, functional, and capital. And the other thing is to note is that a functional program is actually a living document. It is intended to provide continuous guidance, and it needs to be updated and maintained on a regular basis. So if you look at part one, you will see that the functional program is very well laid out in terms of a suggested format. The other element in part one that's critical to inform operations and help you apply the guidelines is the environment of care. We all know how critical the environment of care is in our healthcare facilities, and the intent of this section is to ensure that facility operators and their designers consider very basic elements of the environment of care, such as the delivery of care model being used, layout and operations, and how the physical environment is arranged to facilitate wayfinding and control the environment and privacy and safety issues. So I urge you to take a closer look at part one because it's really important. That can help you both develop your facility and have discussions with the authorities having jurisdiction when you're discussing details of your design and construction. I want to point out here that these elements are really considered tools. The functional program environment of care considerations in the document are really tools. The only mandatory element of them is that the facility, we require the facility to consider these when doing a project. So hopefully you will see future programs on functional program, both from ASHI or from FGI or even other associations that are beginning to recognize that the functional program and the environment of care are truly critical elements when doing a capital project. The other area where the guidelines affect facility management is the compliance area. It is used for accreditation and state licensure. It's the 2010 edition is referenced by the Joint Commission and CMS. I understand that it's highly likely that the Joint Commission will reference the 2014 edition sometime in 2015, early next year. The document, various editions are also adopted, all or in part by 40 states in this country. And although the number can change daily, at last count, 16 states were using the 2010 edition. The document is also referenced in 60 countries across the world. Now, the document should be considered as a living document. Although we revise it on a 4-year cycle, as you can imagine, individual states have their own individual adoption process, and it can vary greatly in terms of how it's done and how long it takes. Sometimes it's a legislative action that can take years. So as a result, there are various editions in play across the country. And that is why if you do work in other states, it's important to know what edition of the guidelines that is being referenced in that state, if it's being referenced, because the concepts of new and renovation will become even more critical, as you can imagine. It's also important to keep tabs on prior and subsequent or future editions of the guidelines because they can inform interpretations. Sometimes if a particular requirement is being debated with your state AHJ, The way it's been handled, if it's changed, say in a future edition of the guidelines, that can inform your discussion and hopefully to your benefit when you're trying to decide exactly how to apply that specific requirement. And then the final area, general area where the guidelines and compliance are critical is the increasing focus on safety risk assessments. In 2010, there were 5 categories of risk that are in part 1 of the document, and that the guidelines, again, mandates that you consider them when you're designing the facility. And they range from security in a facility to infection control to patient handling and movement. In 2014, we increased that number to 7 because we added patient falls, I believe, or it may have been, and medication safety for that matter. So it's important because of the real increased focus on safety that you do a safety risk assessment, and we ask that facilities do that early in the planning process. Now, the FGI has a number of ongoing initiatives, even though we adopt or rather revise and update the document generally on a 4-year cycle. There are a number of initiatives that continue as in between those efforts, and a lot of that has to do with research. We're currently doing an alarm fatigue study, and we are actually also looking at acoustics in elder care facilities. We've just published a white paper on surface materials, and if you go on the FGI website, you'll see a number of white papers that can help inform use of the guidelines and areas of expertise and areas of interest that we're looking at. We also do a number of educational initiatives on a regular basis. We're actually working with ASHI on an e-learning platform, which we hope will debut early next year, which will allow individuals to log on from their computers and do pods of learning and training on specific areas of the guidelines to help inform your decision making when applying it or using it. And FGI is also developing a series of webinars for 2015 that will provide some more in-depth guidance on the 2014 edition of the guidelines. The FGI is also looking towards the future. And the most important of these is, in addition to ongoing research that we haven't even identified yet, but that we are considering, is this concept of a healthcare colloquium. And we undertook this in September and June of last year and this year. And what the FGI did was we gathered 30 experts and great thinkers in healthcare, and they aren't necessarily designers. In fact, a number of the participants weren't even familiar with the guidelines, but we gathered them for the specific purpose of helping us decide where the guidelines should go in the future. And so the first group in Boston in September of 2013 considered what the future of healthcare would look like in, say, 30 years or so. And they tried to define potential futures. And we took those futures to Pittsburgh in June of this year, and we gathered another 20 or 30 great thinkers in healthcare and said, okay, these are potential futures that we've identified. How do you think the guidelines will be impacted by these futures? And how will healthcare facilities be impacted? And that's given us some great insight in terms of where the future guidelines need to go and how they need to be formatted. So it's possible that for the next edition, we're looking towards 2018 at this point. It's possible that you will see something dramatically different from what you've seen in the past. So I urge you to stay tuned, because obviously healthcare is not standing still, and there's no intention for the guidelines to stand still either. So in closing, I'd like to invite you to join or to log on to our website. As you can see on the screen, you can find some more background information on the guidelines. You can also peruse our resources. We have some white papers up there and some other additional information. We have errata also, which will address some things that we may have missed in the guidelines that we need to correct. So I urge everyone to take a look at our website to gain further insight into the guidelines. So I want to thank you again for this opportunity. It's been a little tough speaking to my computer, but I hope that it comes through loud and clear for you. I just want to point out that, as I noted earlier, we did publish and issue the 2014 edition of the guidelines earlier this year. We now have a separate document, one for the design and construction of residential health care and support facilities, and we have a document for design and construction of hospitals and outpatient facilities. So those are two separate books, and I think, as I indicated earlier, stay tuned because it's possible in 2018 that there may be a third book. We may separate out outpatient facilities because of some of the insights provided in those colloquiums that I mentioned earlier, that suggests that we need to focus a little more on outpatient because there certainly is a concerted effort to move healthcare into lower cost settings, and outpatient facilities are becoming increasingly more utilized and more popular. So stay tuned for that potential in 2018. Thank you very much, and I hope you enjoy the rest of your course.